Good morning, good afternoon. Good afternoon. Welcome, everyone. Dr. Noma, do you think you will be able to start? I'm still trying to see if Dr. Nozipo is around. It seems she's not yet in. If at 3 o'clock she's not in, will you mind starting the meeting?
Yeah, that should be okay. Yeah, that should be all right.
Okay.
Are you getting me?
Yes, we are.
Okay, no, that's fine. I'm ready. Let me see if I can go to share my screen.
Okay,
I was having a challenge with my screen at the beginning.
no problem.
Okay, you'll probably need to stop screening so that I can try putting up my presentation. Because it's saying one participant can share at a time.
Yes. Okay, you can try and share your screen now.
Okay. Wait a minute. It's not going to my you may have to screen on my behalf because it's not going into my folders.
Not a problem.
Let me see.
So if I'm screen sharing, this will be your presentation.
Okay. Let me see.
Okay, can you see it now? I'm sharing on your
Just a
behalf.
second.
Oh, okay.
Okay. Yeah. Yeah,
Okay,
that would be my presentation.
that's fine. So you let me know. I can screen it for you from this end.
Okay, I'm good to go once you are good to go.
Okay. We'll just wait for 3 o'clock and we wait a bit for Dr. Nosipo to enter the room.
Okay then.
Dr. Mba, can you hear me?
Hello?
Hello, this is Val Martin. Do you
Hi, Val. Yes, we can hear you.
I just wanted to test whether I could share my screen. I'm not sure that mine would come through.
Not a problem. I think you can do that now.
I try here.
Yes.
Is that coming through?
Oh, yes, we can. We can see. Yes, we can see your screen.
All right.
Awesome.
Exit. Thanks
Fantastic. All right.
So how do I stop screen sharing then?
Yes.
Stop share. That's the one.
Yes. Stop share.
Yeah. Thank you.
All right.
I'll go on mute again.
All right. So we should be starting in earnest at 3 o'clock in about 5 minutes. Right. So I've just confirmed with Dr. Nozipo Maraire. She should be joining us anytime soon. But in the meantime, I want to acknowledge the presence of Mr. Makarao, who is one of our most senior neurosurgeons in Zimbabwe. Professor Jacob Mufunda, Dr. KitKat is coming in, and we have various participants from Yemen, from Zimbabwe, from Saudi Arabia, from Nigeria, and we are happy that Ms. Val Martin is with us. She should be presenting soon. Looking forward to her presentation. So our presentation is also live on our YouTube channel. We have sent in the link into the chat room. At this point, if you have any comment, any question that you want to pose to the presenters, you can just type them onto our Facebook page, on our YouTube channel, or right here in the chat. It's 1 minute past 3. I'm looking for Dr. Nozipo Maraire. She had indicated that she was logging in. She's our first presenter of the day. Thank you, Dr. Maraire, for joining us.
Sorry, guys, just needed to unmute. Good afternoon.
Good afternoon, Dr. Maraire. Are you ready to start?
I am.
Okay, great.
So let me
Awesome.
just get my slides up for 1 second and we can go. So I had them up. I'm not sure where they went. Give me 1 sec. Okay, can you see that? Are you able to see my screen?
Not yet.
Okay. So let me go down to see if I can share screen. Sorry, just give me a sec here. Okay, it won't.
Okay, so while Dr. Marari is setting up, we are just starting. Dr. Nozipo Maraire is an acclaimed Zimbabwean-born neurosurgeon. She is a writer and entrepreneur. She is the author of an acclaimed book called Zenzele, A Letter for My Daughter. The novel was published in 1996. It was a New York Times Notable Book of the Year and a Boston Globe bestseller. It has been published and translated in over 14 languages. She lived and worked in the United States for 30 years and returned to Zimbabwe in 2012 to open her own neurosurgery practice and help improve Africa's healthcare and economy. So, the person we are going to listen to today, Dr. Maraire, she attended Dominican Convent High School in Harare. She received her undergraduate degree from Harvard University, and then attended the Columbia University College of Physician and Surgeon in New York City. She completed her neurosurgery training at Yale School of Medicine. She was awarded a Clinical Fellowship Award by the Congress of Neurological Surgeons, which she used to work with Dr. Fred Epstein in pediatric neurosurgery in New York City. She is a public speaker who has been invited to lecture at colleges and universities across the United States and in Harare as well as a TED Talk speaker. In 2010, she was one of the winners of the British Airways Entrepreneur Face-to-Face Award for her entry of Ecosurgical. Her vision for cutting-edge, affordable healthcare in Southern Africa. She is the founder of Ecosurgical. She's also the founder of the Zimbabwe National COVID Action Trust, the ZINC. Dr. Mararia served on several boards, including the St. George's College as a chairperson, the Zimbabwe National Arts Council as a chairperson, the selection committee for the Rhodes and Bates Scholarship, and formerly Island Hospice and a trustee for the Terera Brain Foundation. She's married to an accomplished urological surgeon by the name of Alan Chiura, and together they have 4 children. It will take the whole hour to introduce Dr. Maraire, and I hope I've done justice
Thank
to
you so much.
introduction. Thank you for having you, Dr. Maraire, and I'm so honored and privileged to listen to you.
Thank you so much, Dr. Mba. I hope you can now see my screen.
Yes, we can.
Okay. Good afternoon to everybody. And thank you for taking part of your Sunday where you're supposed to be relaxing and enjoying your family to listen to us. And thank you to Dr. Mba and the organizers, the neurosurgeons, for inviting me to speak. We have a massive topic, and I'm delighted that we have a number of different perspectives to present that topic. So I'm going to run through it, understanding that we have a combination of primary physicians, specialists, junior and senior neurosurgeons, and other colleagues. So I am going to try to do justice to the topic in a broad sense, but also get down to some specifics. The nature of my talk will be that I will give you some preliminary definitions. I will give you some examples of the kinds of things that are managed for back pain, the immensity of the problem, and some examples in surgery where I think we've done a good job in terms of managing back pain, and then some areas within back pain management surgery where we have not done such a good job. And then afterwards, depending on the speaker, on our organizer's intention, I can take questions immediately or thereafter. So I'm going to launch into the, I put evaluation and management of low back pain, even though it's supposed to be managed, because I think the evaluation bit is critical to our ability to manage back pain. That's, hold on, sorry. I'm trying to get it to play and it doesn't want to play. Okay, I'm really sorry. I'm having I don't know why it's not sharing my.
Not a problem. We can see your screen. You could maybe use the buttons, the up and down buttons on your computer.
That's what I'm trying to do. It's fine. Let's just, there we go.
Okay, great. Awesome.
Great. Okay, so we're back. Some definitions. Just quickly, we all know we define back pain by time. So there's acute back pain, subacute, and chronic. The acute is the less than 6 weeks. We often don't see that unless there's significant trauma. As neurosurgeons, certainly the primary care physicians see that. We tend to see the subacute that are referred to us as specialists. And also the chronic, when really there's sort of a dilemma as to how to treat those patients. We also define it by symptomatic pattern. So whether it's mechanical back pain, non-mechanical back pain, or referred back pain. So a little bit about the epidemiology. We know that this is a major problem. And for neurosurgeons around the world, I know in my practice in the United States and here in Zimbabwe as well, back pain and the management of it consisted about 70 to 85% of my practice. So it is the bulk of what you're going to see in private practice, is also the bulk of what you see generally within the community. At any given point, it's estimated that almost about 10% of the population has low back pain, probably closer to about 1 billion people at any given time, given the global population now, but generally the estimates are about 635 plus million people. There's about 40 to 80% prevalence in a lifetime, and the most common cause, back pain is the most common cause for loss of work, disability, and pain. The US estimates that they spend about $50 to $80 billion of loss, economic loss, on back pain. And that the female and male prevalence, interestingly enough, in the US in particular, is equal. So here's some of the differential diagnosis, because the back pain is caused by a plethora of different things. We have mechanical low back pain, lumbar strain or sprain, the degenerative disease, spondylosis, facet joint issues. We have diffuse idiopathic skeletal hyperostosis, for example, spondylosis, spondylolisthesis, and the diagnosis that we're most familiar with as neurosurgeons: spondylolisthesis, herniated disc, spinal stenosis, and osteoporosis with compression fracture, traumatic fractures, for example, and then various congenital diseases, which can cause severe kyphoscoliosis. We also should be aware when we're making our differential diagnosis of the non-mechanical spine diseases, such as neoplasia, infection, including osteomyelitis, which can occur in a post-operative scenario, inflammatory arthritides, including ankylosing spondylitis, as well as visceral diseases. I will have a shout out here to my husband's specialty, because renal diseases, including kidney stones, pyelonephritis, they can also mimic back pain, and we should be aware of those as we're making our diagnoses, even if often we get referrals that are kind of teed up with an MRI. Don't forget to include the broad visceral diseases within the differential diagnosis. And I would just like to spend a moment deliberately on the diagnosis, particularly for neurosurgeons, which is that in order to manage back pain properly, we need to make sure that our history and physical is accurate. Because we often get referred patients that have an MRI and an exam from their physician, it can be tempting to sort of jump straight to surgery, but we need to begin with the basics, which is a history and physical. If the patient has right-sided pain and they have a huge left-sided lumbar disc, they don't qualify to have surgery. So the history and physical have to fit. The neurological exam has to fit. The radiographic studies have to fit, and the laboratory tests also have to fit. Because surgery at the end of the day is really to address a very specific symptom, complaint, or deficit, And it's only in conjunction with a history, neurological exam, and radiographic study that correlate. Otherwise, you will not get the outcomes that you need. The MRI on the right is clear. That is a surgical problem. It's a herniated disc. It's clear that no amount of physical therapy is likely to alleviate the symptoms of the patient, and it's likely associated with clear neurological deficits. So the role of surgery is about solving a specific problem. Unless you're doing reconstructive surgery, we're really not here to reconstruct somebody's spine or make it look better. I'll never forget one of my favorite professors at Yale always said to us, you treat the patient, not the MRI. So no matter how bad the MRI looks, if it doesn't correlate with the patient's symptoms, your surgery is not going to work. So what are the indications for surgery? There are multiple articles that really address this issue because surgical intervention for low back pain has become incredibly controversial. And it's generally agreed upon by most specialists and with double-blind studies that there's only a few areas where low back pain and radiculopathy require surgery. So intervertebral disc herniation, degenerative spondylosis, spinal stenosis, and lytic spondylolisthesis. And I want you to notice that here is not sort of general back pain. We need to find very specific causes that allow us to manage this surgically. 85 to 90% of back pain does not require surgery. It is really the minority of patients that come to your office that are going to need surgery. And even if you're a specialist neurosurgeon, they have one of these entities, I would still strongly urge you not to jump into surgical intervention because many of them have been shown to be adequately managed with conservative therapy. I know we have a physio that will be speaking to us, as well as I think interventional radiology. So I think that really it's important that even if the patient does have the clinical symptoms, does have an MRI that correlates, surgery still doesn't qualify as the first modality to employ unless there are progressive neurological deficits, Cotter-Equino syndrome, severe debilitating pain, or the patient's already failed to improve with conservative management. Now the biggest topic for us in terms of management, I cannot emphasize, and I think those who have been in practice for any period of time understand patient selection is critical to achieving excellent outcomes. So we know that management of back pain is largely a conservative, non-surgical area. Within that small area of those patients that need surgical intervention, we want correlation of the exam, the radiographic studies, the history. And then even if all of those things, all those boxes are ticked, patient selection is critical to getting good outcomes. This is a really great study that was done in the Journal of Allied Health, and they looked at investigating and predicting the early spinal surgery outcomes. And many articles have been written about this, and this one just goes back and sort of correlates with many of the previous articles. This one was done in 2016. They put special emphasis on preoperative assessment, including psychosocial profile. You can do it as a doctor, as you get a feel for your patient, but you can also employ more formal psychosocial profiles and pain scales, such as the SF-36, the visual analog scale, etc. Also, the Beck's depression scale is one that you may want to use if you feel that the patient has got a psychosocial profile that may be problematic. Gender is also very interesting, correlated with good outcomes. Smoking is a really big red flag in terms of getting decent outcomes, no matter what surgery you do. Obesity, use of opioids, addictive behavior, how long they've been on pain medication, the general attitude towards opioids is also a critical part of the success and management. People who have any workman's compensation or secondary gain have been shown to have particularly poor outcomes. In one study, workman's compensation claims, and we don't have it as much here, but there is this element of secondary gain. They are likely, no matter what the surgical approach is, no matter who the surgeon is, and no matter what the diagnosis, to end up with 80% worse outcome than somebody who doesn't. Similarly for smoking. I had a patient who came from the United States Embassy, and they have a very generous compensation for people who have back pain and back pain issues. And I found that that really fed into the patient's inability to get over their pain. They were not looking for solutions. They were looking for medical leave. It was very much of a red flag. So I would be on the lookout for patients who have secondary gain issues. We don't have a very robust workman's compensation system here because of our economy, but be on the lookout, because no matter what you do, those patients will have poor outcomes. So surgical management. These are some of the common surgeries that we do: lumbar laminectomy, lumbar discectomy, lumbar foraminotomy, posterior lumbar interbody fusion, transforaminal lumbar interbody fusion, any sort of fusion, kyphoplasty, disc replacement, and then fracture dislocation repair. These are the entities really where surgical management has shown to play a role that is constructive, that is associated and correlated with good outcomes, that have clear techniques. Other things such as injecting the disc with collagen, thermal discectomies, those things have not been shown consistently to have appropriate outcomes. I haven't listed them here because many of them are largely experimental and haven't shown to have improvements. Similarly, I've had several patients who've gone out of the country for stem cell surgical management of back pain. I have not seen consistent results that show that that improves the outcome, and several of my patients have had to have repeat surgeries because of those failed management platforms. So I really would like to run through some of the entities for which surgery we've done well in terms of neurosurgical and surgical management. I'm cognizant that there are 3 other speakers, so we're going to run through just the ones that I think are most illustrative of successful surgical management of back pain. So spinal stenosis, many of you know it's a degenerative disorder. It starts with loss of capacity of the disc to manage stress. So the disc degenerates, it decussates, it loses a lot of the internal moisture and elasticity. This puts more stress and shifts the stress to the posterior structures. And that leads to facet degeneration, ligamentum flavum hypertrophy with buckling of the ligamentum flavum, and ultimately narrowing of the spinal canal. This develops the symptoms that we all know fairly well for neurosurgeons and many primary surgeons, which is neurogenic claudication. They have a flex forward posture. They can't walk very far. This can be associated with a dull low back pain that's across the right and a band across the back. They can also be associated with radiculopathy, and in a critical spinal stenosis, you'll get bowel and bladder symptoms with cauda equina compression. So I, as many of my neurosurgical colleagues know, am a proponent of minimally invasive surgery. That's what the capital M, capital I, capital S stands for. And I just want to show you the results for surgical decompression. We have moved from just having decompression. When I first got to Avenues, every surgery I did was listed as a decompression. And I really worked with the staff to say, no, there's a number of different ways that we're doing this now. There's foraminotomies, there is far lateral disc decompression. There's a lot of lateral recess decompression. So we have to be very specific, and surgery has moved apace. And for the primary physicians among us today and for non-neurosurgeons, I would just like to stress that the back surgery that you envision or that you knew is not the back surgery that's being done today. It's really, the technology has moved tremendously to create a scenario where you have a lot less morbidity and a far higher success. So on the left, the MRI, you see spinal stenosis. You can see clearly where the compression is due to a combination of anterior disc compression and posterior elements coming in with ligamentum flavum hypertrophy. In the adjacent sagittal image, you see that there's been decompression, but you also see there's been preservation of fundamental of the spinal structures. In the old days, you would remove the spinous process. We don't do that anymore. And you can see that here on the two right-sided images. The left of those two axial images of the lumbar spine show the severe spinal stenosis, and the right one shows the post-decompression picture. And you can see that at the level of the lamina, there is preservation of most of the lamina. There's a small cut where the approach is, and there's preservation of the spinous process. This surgery was first described by Spetzler in 1997. As many of you know, he's at the Barrow Institute. And what they did is they replaced the midline subperiosteal bilateral dissection and spinous process removal, which was the classic decompression, with a midline but unilateral approach, tubular transmuscular approach. They found that the reoperation rate went from as high as quoted to 50% in the literature to down to 5.8%, and the fusion requirements went down to 3.3%. Patient satisfaction went up to 76%. And this is from an article from Hartl. This is here in Zim. This is our own humble theater picture, but what you can see is that I'm operating here in a tube with a tubular retractor. It has bilateral, it's a tubular retractor, and you can see down into the space, and it's a small space. This can be cervical, it can be lateral, but what you do is we're no longer operating through a big midline incision with those big retractors. We're now operating through a tube. So the traditional laminectomy and decompression has been replaced by less invasive techniques. Just to take you back for a moment so that you can understand the approach, and I wish I had an arrow, I don't, a pointer, but on the top you see the basic vertebrae. This is the L2 vertebrae superior view. And what you will notice is that at the lamina, when we do our minimally invasive surgery, we do very little. We just take out a small piece of the lamina. We leave the facet joints as much as possible in place. We leave the pedicles intact. We leave the spinous process intact. What that means is that you are doing a lot less damage than, don't know if I can do this. No, I can't. Okay, a lot less damage than you would with the standard approach. So much of the architecture of the spinous process remains intact. And this is really important in terms of our success with what we've been able to do. So now I've got a problem. I was trying to annotate and that didn't work. So now I've got to get out of that. Yeah. Okay, great. So this is the minimally invasive view. For many of you that are not involved in minimally invasive surgery, I'm stressing this because I want you to understand how much back pain management, surgical back pain management has changed. So the number A, or letter A, you see a view. On the right hand is a box where you can see the macro view. You see a tube. That tube is what we operate through. To the left, you see the actual view through the tube as the surgeon sees it. There is the midline epidural fat. There's a spinous process, which you see in shadow in the background. And the ligamentum flavum, you can see that's the large ligamentous structure that we often have to remove to get adequate decompression. And you can see the yellow-gray, it's the lamina, the inferior aspect. At B, you see the structures such as the spinous process, the epidural fat, the ligamentum flavum are all featured. What is different here is the lamina that's taken out, and we often call it a laminotomy. It's a small amount of lamina compared to what would normally be removed. And then in C, you see the removal of the ligamentum flavum, and in D, you see that we're down to the dura, and then in E, you see that we're going over to the contralateral side. So coming in from one side, you can actually do a decompression onto the contralateral side without having to take the spinous process off. So at all times, the spinous process remains intact. What you can do is change and alter the angle of the tube, which allows us to do a lot of surgery just from that tiny hole. So from that tiny hole, you get a complete bilateral decompression. You can reach to the contralateral side and actually do open up the foramen on the side. The first time I saw this, I couldn't believe it, but the results are actually astounding. And this works for lumbar spinal stenosis as well as spondylolisthesis. So it's a very powerful tool to preserve normal anatomy while decompressing the spinal canal. If there are complications, they can be taken care of through this. So if we get a CSF leak, for example, you can take care of them through this incision. It's very rare that you would need to make a bigger incision, and you can do multiple levels with a small incision like this. And I don't think we're quite at the end, but anyways, the thing is sometimes less is more, and that is the sort of the famous quote from minimally invasive techniques. Rarely, in spondylolisthesis, for example, we often have to do a fixation, and I've shown you at the top the pedicle screw fixation, and then as neurosurgeons, I think we are also happy because there are a number of lesser invasive fixation techniques. These are both mine from surgeries, and the bottom one is what I call a butterfly, but it's an interspinous fixation technique. For grade 1 spondylolisthesis, which most people, that is what most people have, this interspinous fixation has been shown to be as effective as 4 pedicle screws. And I use it in conjunction with an interbody graft, and it yields very good results. It does so with minimal amount of blood loss, minimal amount of time in hospital, and they wear the brace, but the discomfort is far less than you have with pedicle screw fixation. So spondylolisthesis, as many of you know, this is it's the malalignment of one vertebrae upon the other, and it really has the impact of causing central stenosis, as you can see in the central middle MRI. The picture on the left with the yellow and the blue shows you the mechanics and shows you how you get multiple nerve root impingements. So this is an L4-5 spondylolisthesis. It causes central stenosis, but also lateral recess stenosis, and gives you the L5 nerve roots in the lateral recess. It gives you the sacral roots, which are descending. And you can see that on the right axial MRI, that you get multiple nerve roots affected. So don't be fooled. This has the impact, even though it's L4-5, of doing L4-5 as well as S1. And there are multiple modalities of dealing with this entity, spondylolisthesis, spinal stenosis. This is a biportal endoscopic procedure. For example, I know that Dr. Mawere, for example, does a lot of endoscopic spinal surgery. I do minimally invasive through a tube. Others have many different ways of doing what is essentially microscopic spinal surgery. So it's not the big, huge macroscopic surgery that people used to hear about and that many people fear. This is now really a microscopic operation. The other area that I would like to discuss briefly before we finish is just, and where I think that management of back pain is changed dramatically and works very well, is with compression of spinal compression due to osteoporosis. You get these compression fractures. Before, when I first started doing this and when kyphoplasty was first introduced, this is probably about 15, maybe 20 years ago, the recommendation was that patients would be in bed for 3 months, and if they didn't get better, then you could do any of these vertebral kyphoplastic techniques. Now the recommendation is that it is a primary treatment modality, so you don't have to have your patients in a brace for 3 months, 6 weeks, or whatever. If they have a compression fracture, they can be managed with balloon kyphoplasty. Sorry about the typo there. And I've chosen this particular one because it's an extreme. It's a really significant osteoporotic fracture. And you can actually get the balloon kyphoplasty needle into this small wedge that's left and balloon it. And I'm showing you, this is actually our patient. And on the right hand side, I'm showing you, I'm sorry, I actually have no idea how to go back. So there, I've shown you the technique that we used. You can see that it was almost a flat, almost a planar fracture. The two needles coming in are balloons, and you can see in the lower right picture filling that fracture with surgical cement, essentially, and that stabilizes the fracture. The pain relief is immediate. So if you have an 80, 85-year-old, 90-year-old person who has an osteoporotic fracture, for them to be in bed for 3 weeks to 3 months is devastating neurologically, medically, and for quality of life, and many complications. Acknowledgement of that has led, and research has led to people recommending that this is a first-line treatment. So balloon kyphoplasty is a very effective treatment. It doesn't have many of the side effects of the vertebroplasty, which included extravasation of some of the glue. So for our primary care doctors, we inject the glue with balloon kyphoplasty. It solidifies almost immediately. In fact, you have to be a bit quick once you've mixed it to do the surgery, because if you're not quick enough, it starts to cement before you can, and you can't now push it into the space. In vertebroplasty previously, it was much more viscous, and therefore you had pulmonary emboli or complications due to extravasation of this cement. But with the balloon kyphoplasty, it's really good. And I have had, knock on wood, really no complications with procedure whatsoever. It's very well tolerated. I do it under general anesthesia. There are people who say you can do it under local if you have a very severely sick patient. I have not done that yet, but the results are excellent. I mean, your success rate is 96%. In an older patient, they can get back up and on with their lives. This is a Journal of Neurosurgery article from 2014, and really they're talking about surgical management of lumbar spinal stenosis. This is comparing minimally invasive procedures with an open laminectomy. And again, my emphasis here is for many of our primary care docs and people who are accustomed to the old wide open laminectomy, to reassure you that things have changed and that referral for neurosurgeons for this kind of surgery really is, it makes a big difference to patients' lives without the morbidity and mortality. And so they showed ultimately, they used the VAS and the SF-12 for quality assessment. They compared minimally invasive with open cases. And what they found was a shorter length of stay in terms of surgery, less time to mobilization. If you look at the bottom two lines, time to mobilization was cut in half, and less likely to use opioids, which is a big deal, and shorter time in the hospital, and also blood loss was very significant. Here in Zim, I did an analysis of 300 cases that I had done of minimally invasive lumbar surgery. We're now probably up to closer to 500 cases. And I hope that the data will be able to correlate the data for you guys and show similar results. But we looked at our outcomes and compared it to the studies done by the Journal of Neurosurgery. And essentially our length of stay was anywhere from 3.8 to 4.8. We had 8 to 24 hour early mobilization. There was a decrease in pethidine use, where we only, I would say in 98% of our cases, we use pethidine for the first 24 hours, then we take it off. And our estimated blood loss is minimal. So even for 2 levels, it's really minimal. And so our results hold up very favorably to international results. Our complication rate was at 6%, which held up very favorably even for redo surgeries with international data. So I think we've done very well on certain cases in terms of surgical management of low back pain. Here is an area to conclude where I would say we have not done very well, and I would like to caution both our orthopedic colleagues and ourselves as neurosurgeons into what can happen. This is sort of surgical management of low back pain gone bad. So in the United States, when I was there, there was a meteoric rise in spinal fusions for low back pain, for degenerative disc disease, and spondylolisthesis. This is an article from Australia from 2016, sort of mimicking that same trend. And what they found is that for spinal fusions, there's been an increase of 267, almost 300% over a 20-year period in the US, and then 175% in Australia, where they were getting 8.4 per 100,000 to 23.1 per 100,000 for spinal fusions. And of those, about 3/4, 70% were instrumented. So the increase is 10.8 in private hospitals. There was no difference really between ALIF, PLIF, 360-degree fusions. And they note that there's really no randomized study that supports spinal fusion for degenerative disc disease alone. So if you have radiculopathy, if you have a herniated disc, this is different. I'm talking about just someone who just comes in and says, I have low back pain. When I was in residency, there were these, they would inject the disc and they would inject water in the disc. If the patient had pain, then they said, yeah, that patient needs fusion. These turned out to be extremely controversial. This is where we can actually catch ourselves in Zimbabwe before it gets to the stage of many of these Western countries that have focused on instrumentation fusion for low back pain without really good indications. A lot of it is driven by reimbursement. As many of you know, especially you're a neurosurgeon, if you do a simple laminectomy, you get $5. If you do a laminectomy fusion, you're going to get $10 or $15. And I think that's what drove a lot of the people overseas to do this. And it has been a devastating trend. Patients come with 3, 4, 5 fusions. They're fused from C7 to S1, or more like C1 to S1, and it's been awful. And I hope that we don't see that here in Zimbabwe, that we're very careful, that we're very specific and intentional about the kinds of diagnosis that we treat with surgical management. As I said at the beginning, they have to be specific, correlate with the MRI, the history, and the patient's outcome, as well as patient selection, being very careful. So I think that's it. And I would like to conclude with just this saying that sometimes less is better. And thank you very much for your attention. I'm going to try to mute and unshare my screen. Thanks again for your time.
Thank you very much, Dr. Marire, for your presentation. It was very informative. It is interesting to note that about 1 billion people suffer from back pain throughout the world. And interesting enough, epidemiologically, the male to female ratio seems to be equal. I would have thought female will have more incidence of back pain than male. Is there any?
That's very interesting. I also was surprised at this study, and also what they said was that females sometimes don't do as well as males post-operatively. So I think when we look at trauma, males are far greater. In my data with the 300 cases that I had almost equal proportions as well. I think with women, especially in our society, after the back operation, they are less likely to rest. They're being asked to go back to do duties. And so we have to be so cognizant of that in their post-operative care, and maybe emphasize rehabilitation for them post-operatively in a way that maybe you wouldn't be as aggressive for male and allow them to rest. But yeah, very interesting. I agree with you.
True. And talking about your series as well, it was interesting to note that the average weight was 90.8 kgs. And I think it also feeds into the notion that when you're overweight, the incidence of back pain seems to be greater. And so it's quite telling.
You're absolutely right. And patients that we've sent to do weight loss, there's a patient that came to me, there was no way. I just told her, you have to go get bariatric surgery. Nothing I do is going to help you. She had an MRI that showed stenosis. She had the symptoms of stenosis, but you just knew that doing her was not going to help. And she had bariatric surgery, and she's actually much, much better. So I think, again, it also speaks to prevention is better than treatment, getting the word out there. And I think especially among us females, within the African community, we really need to work also on health maintenance, so that we don't get to the point of having obesity. And I talk to my patients a lot about core strength, back strength. It's really an important thing to emphasize when we're talking to our patients.
Awesome. Thank you so much. If there is no further question, I can't see any question in the chat. Thank you so much for your presentation, Dr. Maraire. Our second presenter is Dr. Nomakwawe Moyo. She was in, I think she's still in, I hope. Dr. Moyo is a physician anesthetist with special interest in pain medicine, including pain education and curriculum development for pain management. She's a WFSA fellow in interventional pain medicine and also a faculty member at the University of Zimbabwe Faculty of Medicine. She is a co-founding trustee of Read to Lead Zimbabwe. And she's been involved in a lot of philanthropic activities, like helping children to read, collecting pre-love and new reading books for the less privileged communities, and setting up mobile libraries. It is our pleasure and really our honor to listen to her. Dr. Moyo.
Thank you, Dr. Mba.
Awesome.
Yeah, I'm still having a challenge with sharing my screen. Are you able to screen for me?
No problem. I'll do that.
Okay. Thank you. While is doing that, thank you for having me on this platform. Excited to be part of this presentation. I'm going to come from an interventional pain point of view. You could start the slideshow. Okay, thank you, Dr. Mba. My task is to give a brief talk. I was told exactly 15 minutes on the role of interventional pain medicine in the management of back pain. Next slide. Next slide. I have no conflicts of interest to declare. Next slide. So the objectives, I've really put out two items there to say, briefly define what interventional pain medicine or interventional pain management, as some would address it as, and what role IPM has in the management of back pain, and in 15 minutes. So what is it? What is interventional pain medicine? Next slide. According to the American Society of Interventional Pain Physicians, interventional pain management is a discipline of medicine devoted to the diagnosis and treatment of pain-related disorders. Interventional pain medicine utilizes a multidisciplinary approach, or what we now refer to as a multi-professional approach, in which a team of healthcare professionals work together to provide a full range of treatments and services for patients suffering from chronic pain and or acute pain. The goals of interventional pain management are to relieve, reduce, or manage pain and improve the patient's overall quality of life through minimally invasive techniques, specifically designed to either diagnose and also to treat painful conditions. IPM also strives to help patients return to their everyday activities quickly without heavy reliance on medications. Next slide. This is a slide which just depicts the different professionals that are involved in the care of patients with chronic back pain, that is low back pain. And you can see it's a whole spectrum. It's a comprehensive, it's not a comprehensive list, but it's a whole spectrum of professionals who bring in their different expertise, because for a comprehensive holistic care program for a patient suffering from chronic pain, you will need psychologists to take care of the psychological side of things. The psychosocial profile of patients need to be assessed and taken care of. Surgical specialists come in if there's a need for surgical intervention. The primary care physicians are usually the first to see the patients and the ones to refer and escalate care to the next level of professionals. And if they are not aware of the comprehensive needs of the patients, you may find that there is usually a silo-back approach to the management of a patient without the psychosocial or biopsychosocial approach to the management of pain. And you'll see there are physical therapists, occupational and rehab therapists. They have a key role in the in the rehabilitation and the maintenance of avoidance of deconditioning in patients with chronic back pain. And in social workers are needed in some circumstances, because as you are aware, low back pain is usually associated with a lot of social problems, financial problems, work stoppage, patients being laid off work, and their personal financial needs may go unaddressed. Community nurses have a role to play. Lifestyle coaches, as Dr. Maraira explained, that some patients have got issues with obesity and psychosocial problems, and you will need to involve these kind of professionals to give a holistic, comprehensive management to a patient suffering low back pain. Next slide. Back pain really is the penalty that we pay for our upright posture. Next slide. The causes of back pain, our previous speaker has given a comprehensive approach to it. I'll just rush through it just to give it from an interventional point of view. Really, like I said, IPM procedures are meant to be minimally invasive procedures targeted at the pain generator. So we usually tend to dwell more on the question, what is the pain generator in this particular patient? And she has mentioned all the conditions. It could be facet disease. Is it sacroiliac joint? Is it disc disease? Is it a disc which is just bulging? Is it an annular tear? Is it a grade 4 annular tear with nucleus pulposus leaking into the into the spinal cord and causing direct chemical irritation to the spinal nerve? Is it a vertebral body compression fracture? Is it because of osteoporosis, or is the fracture due to spinal meds and the ligamentum flavum hypertrophy issues? So as IPM, when we're deciding to say what intervention are we going to do to this patient, we need to have a diagnosis of, say, what is the pain generator, and not to say, in some cases, the pain generator may be unknown. Next slide. This slide is really just showing the different components of the lower back, which may be the possible pain generators. Next slide. So what are the pain sensitive structures in the back? The things that we need to have at the back of our mind as we're planning for interventional procedures on the patients. We need to understand that the vertebral periosteum and end plate are highly innervated, and they are sources of pain. In the disc itself, the posterior outer 3 millimeters of the disc, which is in the annulus fibrosus, is innervated by the sinovertebral nerve, which is a branch of the anterior branch of the ventral ramus. It is the most sensitive pain. That's why patients with an annular tear have severe backache. The facets are innervated by the middle branch of the dorsal ramus, and they are a source of pain in most patients. And some patients develop subchondral cysts in the facet joint itself, because the facet joint is actually a pure synovial joint and can suffer arthritic changes like any other synovial joint. And then some patients do have pain because of direct nerve compression, and usually they present with low back pain with radiculopathy and all the symptoms which the previous speaker has alluded to. And sacroiliac joint is also a synovial joint, which is a capsule, and patients may present with low back pain. Next slide. Next slide, Dr. Ba. Okay, I'll just skip through this slide because this was just a cartoon diagram just to show the innervation of the structures that are the sources of pain generation. As we can see there, we've got the dorsal root ganglion and the exiting nerve root, which has the ventral and the dorsal ramus. And for the disc annulus, the innervation is from the ventral ramus. And for the facet joints, we see the middle branch of the dorsal ramus. We've got the muscles like the erector spinae. They are also innervated by the medial and the intermediate branch of the dorsal ramus. And then we do have, next slide. In some instances, when you've got an annular tear, that purple color in there is just depicting the nucleus pulposus, which is a proteoglycan chemical, which causes direct irritation there of the exiting and the traversing nerve roots in the spinal canal. So if a patient has a grade 4 annular tear, they can have severe pain just from the direct chemical irritation without even a nerve compression. Or if there's extrusion and disc migration, you can even, if there's extrusion of the nucleus pulposus and migration of the contents, you may even have irritation a level below or a level above. Next slide. So really, this slide summarizes the IPM procedures that are done for back pain. So usually the first step is to do a diagnostic procedure, which is usually a nerve block. This is to say we need to be sure that the targeted pain generator is the real cause of the pain. You treat the patient and the source of the pain, not the images. So you can do diagnostic middle branch nerve blocks using local anesthetic and steroid injections under fluoroscopy guidance for facet pain. You can do facet joint injection directly into the facet joint, although this is not popular and causes severe pain. SI joint injections can be done. So once a patient has immediate relief from the injection of a local anesthetic onto the targeted pain generator, then the patient qualifies for a therapeutic procedure. Like I said, now most of these procedures are being done fluoroscopy guided or CT guided, and the most common in our setting because are the epidural steroid injections. Radiofrequency ablation can be done, unfortunately, in our setting. We have access to RF machines as yet because of the high capital investment involved. Next slide. Can you skip the next 2 slides because they're speaking to the same slide? Next slide. Yes, I'll just give a brief talk on the steroid injections. The injected steroids are directed, control the inflammatory cascade induced by chemical or mechanical irritation. Like I said, chemical irritation could be from the nucleus pulposus, which is leaked into the spinal canal. Mechanical compression from the 3-joint complex, either facet hypertrophy, ligamentum hypertrophy, or disc degenerative disease of the disc causing disc bulge into the spinal canal, causing spinal stenosis. So irritation, be it chemical or mechanical, induces an inflammatory cascade, which causes an inflammatory soup, which causes direct irritation of the spinal nerve, causing severe pain. So the steroids, once they're injected, they inhibit the release of chemical substances and reduce the pain. So the benefit of steroid injections is to decrease the production of the inflammatory soup and reduce sensitivity of the pain of the nerve fibers to pain. And this improves patient quality of life as it reduces the pain and suffering. And in some instances, a patient has an acute on chronic exacerbation of pain. This can, a steroid injection can break the acute pain cycle. And improvement in or reduction in pain causes, reduces disability, improves the patient's physical activity tolerance, especially participation with physical and therapy and rehabilitation programs. And it also has been shown to reduce the total daily oral medication requirements in patients and may help postpone surgery in some unfit patients while these candidates are being optimized for surgery. Next slide. Efficacy controversies. There's quite a lot of controversies on the efficacy of steroid injections, be it interlaminar, caudal, or transforaminal injections. And available research indicates generally favorable results, and patients experience some pain relief, albeit for some it lasts for a few weeks, for some it may go up to a year. Many studies have documented the short-term benefits. The data on long-term benefits is less robust. Controversy persists regarding their long-term effectiveness in reducing pain and improving function. Literature both supporting and opposing are available. And the major issue really has been methodological flaws in most research because of the heterogeneity of the data involved, and this limits the usefulness of the data. And the major issue has been the mixed bag population. And in some instances, some procedures are being done blindly, but with the improvement in technology, most of these procedures are now being done image guided, either fluoroscopy or CT guided procedures. And generally, it is agreed that an epidural steroid injection seems to be more useful in back pain with nerve irritation, that is from a nerve compression or from a chemical irritation in patients with radiculopathy than in diffuse axial low backache. 3 to 4 intervention injections may be required or in a year. If a patient requires more than 4 injections, generally it's a sign that there is severe disease or there's severe nerve impingement, and the patient may benefit from a decompression. Next slide. The next few slides really is probably repetition, which Dr. Maraire has taken us through. This is just a slide to show that facet arthropathy really mostly goes undiagnosed. It can actually be missed even on imaging if people are not familiar with the MRI or the radiological picture of facet arthropathy and facet hypertrophy. Facet joint injections and RF ablation could be done. Next slide. SI joint interventions with injection of the steroids, and RF neurotomy can be done to ablate the innervation of the SI joint. Next slide. She spoke about the percutaneous vertebroplasty. I'll not go into that. It's the major issue being that it stabilizes the spine and gives a characteristic immediate pain relief, and it's very useful for patients. Next slide. Epiduralolysis. This is done in epidural fibrosis. There's a lot of controversies, and data is really not robust to say what are the outcomes, but this is available in some centers, and they're able to carry it out. The rest of the slide, I think, has been part of repetition on what she has presented on, and can you just go through the slides again to the end? I think she's mentioned that. Next slide. I think that brings my presentation to an end. I'm sorry I could not screen for my laptop, but this is the summary of what IPM has in the care of a patient with low back pain. Thank you.
Thank you so much, Dr. Moyo, for your presentation. I can't see any question in the chat. I think your presentation also spoke to the importance of that psychosocial profiling that was mentioned by Dr. Maraire as well, about the importance of choosing the right candidate. And I was intrigued that when we talked about steroid injection, we have 75 to 80% relief, and the patient may require about 3 to 4 injections per year. Is there any idea as far as the cost of steroid injection is concerned, like in our setting? Is it something that is easily accessible to the majority of for our population.
It's a very interesting question that you've asked in terms of cost. It's unfortunate that I have been coming into this program from an anesthesiology IPM point of view. So when I started doing the procedures like at Parire in the teaching theaters, it's easy. But when it comes to private practice, most patients have not been able to access the care because of the tariff system, which has been there. Most of these procedures have not been put down into a proper tariff coding system, but I'm glad with the ICD-11, which has come now that pain is a disease entity, it's recognized as a disease entity, and it is coded, it should be able to come up with tariffs. In my experience, what I've had to do if I'm doing a procedure in the private sector, for instance, I've had to look at either the radiologist, the neurosurgical, or the physician procedures to say what is the nearest procedure and what is the nearest tariff. And most of the tariffs initially were being done blind, then fluoroscopy guided. Right now, I think Dr. Jaganani is offering a service CT guided. I'm not sure if he's managed to get tariffs for that because that was a major challenge. But I think that should be taken care of with the ICD-11, which has come in. Pain is a disease. It is expected to improve access because even some medical insurers were not paying because there was no code for that for a pain, like a physician anesthetist doing an epidural steroid injection.
Dr. Moyo, thank you so much. I wanted to, if I can just jump in to our chairperson, I didn't know how to raise my hand. I wanted to say that one of the things that I find so helpful with your services and with Dr. Jakanani in particular, who I use very often, is sometimes if I'm not sure, let's say I have a patient who has disc bulges at 4-5 and L5S1, and I want to know which of these is generating the pain. It's so helpful if you have the interventional radiologist give a diagnostic nerve root block, because if the pain that they're describing goes away with either L4-5 or L5S1, then you know what you have. So I find that they're not only good for treatment, but they're also very useful for us, for neurosurgeons, to get a sense of diagnostic. It confirms where you think the pain is being generated from, sometimes when it's not quite clear. So thanks for the presentation, Dr. Moyo, and I appreciate the services that you guys offer. It's very helpful.
Thank you very much again, Dr. Moyo, for your presentation. And in earnest, I think we will go through to our next presenter, Mrs. Val Martin. It is our pleasure to have you. Val Martin graduated from the University of Zimbabwe in 1992. She completed BSc Physio Honors. She worked in Harare Hospital, then locum for 2 years in London. She has done 2 training programs in chronic pain management, one in Cape Town in 2010 and another one in Adelaide in 2017. She has also done postgraduate training in orthopedic manual therapy in Pretoria in 2012. She's passionate about the body's intrinsic ability to heal itself. She has had good success with conservative management of disc pathologies in the lumbar region, and it is really our delight and our pleasure and our honor to hear her speak to us about her experiences. And over to you, Val.
Thank you. Thanks so much, Dr. Mba. I'm very happy to be here with you today. I'm hoping you can hear me. Is that all right?
I can hear you.
Okay, now I'm hoping you can see my PowerPoint.
Not yet.
Not yet? Okay. Anything yet? No?
Not yet.
Okay, hold on a second. Try again. Yes?
Yes, it is awesome.
All right, let's get on to slideshow. All right, so I am delighted to be with you. It's a great privilege. I'm hoping you can see me, only because I like to see the person who's speaking to me. So I hope that helps you.
We can see you and we can see your screen.
And if you get distracted by my presentation, you can look at my glasses or my earrings or
Right.
something. Okay, so I'm officially a pain ambassador. I'm hoping that it's not that I cause a lot of pain, which I'm renowned for with my elbow in somebody's bottom, but that I'm a chronic pain ambassador, in that I want us all to be on the same page when it comes to chronic pain. So here we go. When I was asked by Dr. Mba to share, there were 1,000 things that I could share. I could share about what I do, which you're welcome to ask me about. But I treat backs with my hands and sometimes my elbows, and remarkably, they often get better. So I'm very, very privileged to see a lot of people with back pain, and we seem to have a good result for one reason or another. So I'm going to just go on to chronic pain, because we all know that it's the patients who we can't fix that drive us mad, not so much the patients that we can fix. So I just wanted to quickly feed back to you. I often obviously spend maybe 6 sessions with people. That's around about 5 or 6 hours in a month or so with people. So the feedback that I have, really to the doctors whose patients I see, or the surgeons, they've seen the surgeon and then they come back to me and they say, "Oh, he was such a nice guy. What a great guy. He's such a nice guy." Or, "Oh, they only gave me 5 minutes of their time and they didn't even examine me." Or, "Wow, she's amazing. She's very short, but very smiley." And so I get the whole range of people, what they say about you. So what I want you to know is that the therapeutic relationship is far more important than I think we realize. People are coming to us for help. They're desperate. They've been in pain for some time, and they really are needing encouragement and someone to walk with them. So there's that saying, people don't care how much you know until they know how much you care. And it's very important as health professionals that we convey that we actually really do care about them, and that in itself is very healing. They need to know they're not just a number. So we're all on the same team. We all want the same thing. The physio, the surgeon, the doctor, the psychologist, everybody and the patient all want a lovely, pain-free, mobile spine. And that's really what I'm talking about today is team. How can we help the patient get better together? So we're talking more about disability today, the concepts of pain and disability, risk factors for disability, which I'm sure you're aware of, and how to really intentionally target those risk factors. So we know that chronic pain is pain that persists past the point of healing. Now that does our brains in a bit, because we suspect the patient has healed, but the pain hasn't changed. And not only is the patient post-surgery upset that the pain hasn't gone, but the surgeon is upset that the patient's pain hasn't changed. And especially 3 months or 6 months later, the patient's pain hasn't changed, and it should have. So this graph shows us the difference between acute pain and chronic pain. Obviously, within 3 months, we expect that acute pain is resolved. Chronic pain does this weird thing that it just carries on, and there are good days and there are bad days. And And what we want really is to make sure that they're more good days than bad days. With chronic pain, I'm not sure that we can get the patient completely out of pain altogether, but we want them to have more good days. So that statistic is about 60% of Americans have reported chronic pain at the last. That's 60%, imagine. It's all about how much money is spent. Listen to this, the 10% of back pain patients who do not respond to therapy are responsible for 90% of all costs for back pain. That's distressing, right? And as Dr. Maira said, it's a huge amount of money being spent on low back pain, 1 to 5% of the GDP in Western societies. Days lost due to back pain are on the rise. Okay, so this is we're a little bit out of date here, but still we know that days lost from back pain is still increasing. So it's on the rise. The interesting thing, though, is that the incidence of back pain is not increasing. Let me go back to that. The days lost is increasing, okay? But the incidence is not increasing. What the heck is happening? The disability associated with back pain is increasing. And in fact, disability associated with many medical conditions is increasing in all countries, regardless of the healthcare system. What on earth is happening? So this is very, very important. Pain and disability are not the same thing. There are many people in the general population who have persistent pain, but seem to cope okay, right? We know those ones. And then we know the other ones that find it very, very difficult in maintaining their life roles in the face of ongoing pain. Why? Is it just a matter of pathology or intensity of symptoms? What is the factor that makes some patients disabled and some patients just get on with their life? There seems to be a weak relationship between underlying symptoms and disability. Interesting, because we think, well, they've got a lot of symptoms, they'll be quite disabled. That's not necessarily true. The severity of pain symptoms will not predict who will or will not return to work in patients with musculoskeletal pain. Interesting. Wow. In fact, prolonged treatment of symptoms is more likely to extend disability and delay return to work. Oh my word. The longer the treatment, the more the delay of return to work. Interesting. So what on earth? I'm sure that this is familiar to some of you, the models of pain. Some of our current models of pain imply that if you treat the symptoms effectively, there will be a reduction in disability. Even our current disability models start with the impairment or changes in function. But research suggests that pain only explains about 10% of the variance in disability. Scratch your head indeed. So, if you see pain, so it depends on how you see pain. If you see pain as a measure of tissue damage, an indicator of impairment, which leads to disability and incapacity of work, and if you see physical pain as different to emotional pain, then you subscribe to the biomedical model. And that's, I think, for all of us here, perhaps, we were taught the biomedical model, cause and effect. You treat this, the patient gets better. But we all know that after being in practice for so long, it's not quite true. It's not that simple. We can't explain this. This guy is hanging by hooks in his back and he's smiling. It shouldn't be. The impairment, the actual symptoms, the actual injury should be not letting him smile, that's for sure. Okay, so the biomedical model is weak on several levels. It limits pain to a strict stimulus response. That's not exactly true, is it? We've got a brain in the middle. It assumes pain to be the same as nociception. Okay, I'm not going to go into the physiology of it all again, but nociception is just stimulus response again. There's a brain involved. It assumes the nervous system doesn't change, but we all know now that neuroplasticity is a real thing, right? That's all new research is saying about neuroplasticity is a thing. It takes no account of emotional, cultural influences. It takes no account of the meaning of the experience to the individual. How often when we assess our patients, do we ask, what does this actually mean for you? We're too biomedical. We need to be a bit more biopsychosocial. So, looking for the cause of all symptoms at the level of tissue pathology distorts pain and suffering, damages patients, and serves society poorly. All right, if your mind is feeling a little bit warped, it isn't just because it's Sunday afternoon. It's because this kind of makes us a little bit confused. Well, what do we do with this? So medically, the model cannot, so the biomedical model cannot explain phantom limb pain, okay? It's a terrible, terrible thing. The limb is not there. It shouldn't be causing pain. And yet we know that phantom limb pain is a big thing. Pain in the absence of pathology. We look at x-rays, we look at MRIs, there's nothing wrong with you. Oh, but my back pain is so terrible, it's so debilitating. We're like, well, are you making it up? They're not making it up. They are a whole person. It's not just their body. All right, these are interesting statistics. This is about osteoarthritis. Listen, 60% of grade 2 and grade 3 radiologically diagnosed joints are painless. So I don't want to hear that you had a total hip replacement because the doctor just looked at the x-ray. That is not correct. The doctor must speak to you. I get that so often, that the hip has been replaced because they saw on the x-ray there was no cartilage left, but we know the pain was actually coming from around the corner, from their back, not their hip, because they just treated the x-ray. Like Dr. Maria said, you don't treat the MRI, you treat the patient. And 40% of grade 4, there's no cartilage, joints are painless. Wow, that does our minds in a bit, doesn't it? And rheumatoid arthritis, the disability is much more dependent on the pain, and disability are much more dependent on psychosocial factors than disease factors. Okay, so this is the International Association for the Study of Pain, their definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Pain is always subjective. All right, that's it's very difficult to measure pain. It's always subjective. Obviously, the purpose of acute pain, it gets our attention. It gives us a warning that there's damage coming if you don't pay attention. But it's not enough to feel and experience pain. To be useful, pain must change our behavior. That's why it's there. Pain is there to change our behavior. All right, even now when you're sitting on your chair and you feel your bottom getting a little bit uncomfortable, it's there to make you change, to make you shift. Can you feel your low back is a little bit uncomfortable now? Yeah, we probably should have stood up and stretched about, because the pain is there to get us to change our behavior, right? Okay, so time is crucial when it comes to chronic pain. Chronic is all about time, and that's what Dr. Mariro alluded to as well, that time is crucial. The longer the patient has had the pain, the more of a problem it is. When somebody sits down in my chair and says, oh, I've had this pain for about 20 years, all of us, I think, all of us medical people just kind of hold our heads and say, oh no, what's coming next? Chronic pain and disability are developmental problems. Thoughts, feelings, and behaviors change over time, and time is critical. So here we go. The risk factors, we know that 10% is pain. Oh my word, well, what is the other 90%? Psychosocial factors are even more than pain factors. Interesting. What's the other 40 is 60%? Oh no. This, for medical people, unexplained things don't really fit very well with us. But so 60% of risk factors we just don't know. And that's very difficult for all of us. So I'm going to run through what the psychosocial factors are, which ones are important ones, and how do we address them. So anybody know about catastrophic thinking? Catastrophic or alarmist thinking is, oh my gosh, I need surgery. And they've had back pain for 2 days. Like, no, calm down, wait. Oh, you know, I'm gonna end up in a wheelchair. My mother's had this. She's in a wheelchair. I'm gonna be in a wheelchair. No, calm down. Okay, so when they do that already, we've got a big job. Okay, they're fearful of engaging in activity that might exacerbate their symptoms. Fair enough. With an acute disc, you don't want to bend forward too much. You don't want to sit too much, of course. But a chronic, well, you know, no, I don't go for a walk anymore because I might damage my back. Well, that's a disaster, isn't it? They believe themselves to be severely disabled. Okay, that they can never see their life without this pain. They've had it for 20 years. They can't imagine that their life will ever be without this pain. So expectations that even after surgery or after interventions, the condition will persist. So low confidence in the ability to function normally while in pain. So that's self-efficacy and beliefs of low personal control. I'm out of control. And part of what we do is give them tools so they feel like they have got some sort of control. Beliefs about other symptoms being related to the back pain. I've got a headache today. I think it's my back pain, or yes, possibly they are, but often in chronic pain, they not so much. So psychosocial risk factors, the attitude and belief of your patient. The behaviors of the patient, compensation issues, that's a nightmare for all of us. Diagnosis and treatment, what do they know? What do they fear? What is their understanding? The emotions, their family, their responsibilities in the home, what it means for them, and obviously work. So if we're not asking these questions, we don't know. So these things, these type 2 risk factors aren't usually modifiable or changeable. Their previous history, they might have had abuse in their past, they might have had a bad car accident and they lost their child in the accident. There's other issues that we can't change. Their genetics, their occupational factors, and obviously medical legal issues we can't perhaps change. The type 1 risk factors we can change. As health professionals, we can change. We can change the catastrophic thinking. Stop, that's not true. Let's tell them the truth. Let me tell you the truth. And we as health professionals need to know the truth. You know that A lot of the time, acute discs, they get better. We know that core work helps. We know that posture work helps, that we can get them out of that spiral of catastrophic thinking, fear of symptom exacerbation, disability beliefs, low self-efficacy, giving them tools. Sometimes I'll even tell them to call me if I'm worried about them, or just message me and I will help you. You're not alone. You can do these things to get yourself out of trouble. And perceived injustice, well, that's a very difficult one as well. These ones, perhaps we can change. The vulnerability model. So we know that catastrophizing, pain-related fear, perceived injustice, and disability beliefs, all of these increase pain, distress, and disability. Resilience model, self-efficacy, pain coping strategies, readiness to change, and acceptance, all of these decrease pain, distress, and disability. So we need to tackle those vulnerability factors. Catastrophizing, so they're less likely to return to work. They have a poor response to medication. They have a lot of post-surgical pain. They have more time in hospital. We know all the studies. So catastrophizing is an excessively negative orientation towards one's symptoms and health status. Rumination, they ruminate, they go over and over, obsess about it. They magnify the problem and they feel very helpless. We all know these patients, don't we? It's just very difficult. We need to have the truth at our fingertips, and we need to be very strongly encouraging of these people. So all the results from the neurochemical studies are showing more and more that all thought is a chemical event. You can think something and your pain increases, think something and your pain decreases. There's a lot of science behind this. The neurotransmitters in response to anxiety and stress are pain enhancers. The neurotransmitters for feeling of well-being and all of those kind of neurotransmitters are pain reducing. So it's important to know that. We know this is true. Fear is the engine of avoidance. I'm just quickly going to go through this. So on the right side, this is normal. There's an injury, there's a pain experience, there's low fear, there's confronting the fear, and there's recovery. For the unhealthy or dysfunctional side on the left, we have pain experience, but now we have catastrophizing. They have fear of movement, fear of re-injury, the fear of pain. They are hypervigilant, they don't move, they don't go for a walk, they don't get out of bed, they avoidance, they get disuse, disability, depression, and it increases their pain experience. And here we go around the circle again. I'm going to just skip a few things. I'm sure that we are, yeah, this is what I want to get to. How can we target these? So what I really, the take-home message that I would like for all of us to go with today is we are the agents of encouragement. We are the agents of truth. So we can use those two things to help our patients a lot. So when a patient comes and sits down, I want to know what their goals are. So already I'm looking past this to when you get better, what would you like to do? So already we're thinking positively. We're looking now about getting them involved in activity, just something easy. If they've been in bed all the time, well, maybe let's walk to the kitchen a couple of times a day and see how that goes. So we need to get them active. We need to focus on change, target their disability beliefs straight. And sometimes we have to be quite confrontational. That's just not true what you think. So build in activity goals from the beginning and make life role reintegration a priority, and think about activity. So as doctors and surgeons, it's right on your first consultation. If you are talking future and a bright future for the patient, already they are not so self-focused and so present focused on their pain. You've already lifted their gaze a little to the future. It's not a hard thing to do. So we need to reduce the sensory input. We also need to increase activity and reintegrate into life. And both of those, from both sides, we will address psychosocial factors. So in acute, we do target the symptoms. As we go chronic, we target activity. We know that if you address symptoms too much in chronic patients, you get nowhere. So we address intentionally activity. Okay, so reducing the threat information in a non-threatening way. Pain education is better than structure-oriented education. So often with chronic pain patients, we talk about the alarm system is not, it's a faulty alarm system. It's not that your body is at fault, it's that the alarm system is too sensitive and sensitized, and we've got to use the consciousness to actually dial down the hypersensitive alarm system. Communication skills, to hear the patient's story. Most doctors that the patient tell me about, they haven't heard the patient's story. And maybe it's a time thing, but it's a very, very important. The patient has to be heard and understood so that their anxiety will come down. They will feel happier and they will feel that they can trust you. And then often outcomes are better because they really do feel you care for them. And targeting reintegration is very important. So we can target all of these things, but actually none of these change return to work or life role function unless we be very, very intentional. So return to work needs to be specifically targeted. Return to integration and to life roles needs to be specifically targeted. So chronic pain and disability is a major problem to everybody. Symptom-focused interventions are not enough. Psychosocial factors are very, very important barriers to recovery. Return to work needs to be specifically targeted, and the therapeutic relationship is much more important than we think. Thank you.
Thank you very much, Val, for your presentation. And we see why you are a pain ambassador. It was really so well done. Interesting enough that day lost has increased, but the incidence has remained the same. What do we attribute that to?
So we know as a society, our depression and anxiety levels are higher than ever before. So we know that society going down the tube when it comes to all sorts of things, morality, but psychosocial issues have never ever been as high as they are now, and that's what we attribute that disability to.
Thank you so much. If anyone has any question for any of our presenters, you can just raise your hand and pose your question, or you can type the question onto the chat room or onto our YouTube platform. I wanted to ask Val, what type of patient typically will request for your services? What is your typical patient?
All right, so for some reason, I have the reputation of loving low backs. I do love them and they seem to respond well. So I see a lot, probably half my practice is low back, most commonly disc dysfunction. We have very good results with conservative treatment of disc bulges, even prolapse, and a lot of those actually, even with a bit of radiculopathy, we still get positive outcome, which is remarkable. I am a manual therapist, so I will do a lot of mobilizing. We get a lot of stiffness in the back, so I'll mobilize all the facet joints. I will loosen up all the muscle spasm. A lot of what I do is educational, and why you in this problem is often postural and how we deal with your posture and extension. So we know that a lot of the disc problems are flexion dysfunctions, right? Because the patient's been sitting too much, bending over too much. So we treat dysfunction with extension, and that really helps. I see a lot of necks, I see a lot of shoulders, I see peripheral joints as well. But for some reason, I'm known as the back physio. I think me and Tash Kapeki are the people, but there's no real reason for that.
Awesome. Maybe a question that I wanted to ask as well to Dr. Maraire, to Dr. Moyo, and to yourself is at what point do we have to bring in the physiotherapist? Let's say you have a patient coming in with back pain that require surgical intervention. Is it beneficial to have physiotherapy before, during, or after surgical intervention? What would you say?
Such an excellent question, Dr. Mba. So for me, I found that physical therapy, as Val says, there's so many components, and as surgeons, we only deal with so many. So we have any patient going to surgery have a preoperative visit with our physio. We were doing that for quite a long time. And then when they go into the hospital, we have one of the same person, inpatient physio, our own. I know that different hospitals have their own, but we have one associated with us who goes into the hospital. And that's really just mostly breathing and walking and assurance. But it helps them. For example, I found in hospitals, they don't know how to get in and out of bed. The nurses often don't have the time to get them out of bed properly, teach them proper breathing techniques. So I found it's helpful there. And then obviously we give them a bit of a break, and then at 4 to 6 weeks, they start proper physio as an outpatient. She said with like Tash Kopecki or one of our outpatient people. But I don't think you can get them involved too soon. That's my opinion. The sooner the better.
Yeah, as far as I'm concerned, I'm happy to see them 6 weeks post-op. We would obviously not mess with the surgical side at all, but the stiffness up above and below the surgery, the muscle spasm, a lot of the time at that stage, they're just about ready to do start doing some core work and getting their muscles back on track. I think Dr. Maraire is very good also at doing a 6-week trial of physio often, where we like she said, surgery is a last resort, and if the patient hasn't had physio, and not just TENS and not to discredit our electrotherapists, but we know from research that manual therapy is much more effective than electrotherapy. It's in the research. So I don't mind who they see, but they must get a good series of, I think, 6 weeks of physio. If they are not, I think for me and Natasha, if they haven't improved within maybe 3 or 4 sessions of physio, then I don't think they will improve. I want to see, even at the end of 1 session, I expect to see results. If by 4 sessions they are not improving at all, I'm happy that they go into see a surgeon, and then obviously 6 weeks post-op.
Thank you so much. Dr. Moyo, are you still with us?
Yeah, I agree with Dr. Marere and Val. And really, I think the important thing is getting them to see the physiotherapist pre-surgery, just inculcates that comprehensive care approach to the patient. You know, it helps them improve their compliance, because it's easier to speak to the patient when they're pre-surgery about their expected planned care, that there is pre-operative optimization, prevention of deconditioning. Then there is the intraoperative or perioperative care, which will involve the surgery and the physical therapy perioperative, and then the long-term physical rehabilitation. So involving the carer pre-surgery, sort of like manages, you know, the biopsychosocial model that we're talking about. Introducing a long-term physical therapy program post-surgery. Patients may think, that's what I've picked from some of the patients that I deal with. They may think that the surgeon is now sending me to the physiotherapist because they failed. But if they go to the therapist and they're told this is part of the comprehensive care plan, you will see a physical therapist for a long time, occupational rehabilitation, psychologists, if there is need be, cognitive behavioral therapists. They should be introduced pre intervention, so that they know it's part of the care plan. It's not an additional care or because something else has failed. Everything works together as a package.
Yes,
Dr. Moyo, I just want to pick up on that. Sorry. Sorry, Val. I just want to pick up on that. Val and I couldn't agree more. I think one of the things I push back a lot on with my patients is when they say, you're going to fix me. I find that really absurd, because, as I said, surgery is about creating the space for healing to occur. That's what I tell them. My job is to remove the disc or remove this instability, fix it, so that you can start healing by involving our physios. And Val, if somebody goes to Val for 6 weeks or Tash for 6 weeks and comes back and says, I'm not better, I feel very good about taking them to surgery. And as Val says, you need to know the kind of modalities they're using. The other modalities where I'm not so comfortable, even if they come back after 6 weeks, I'll send them still to Tash or to Val and say, no, do this for 6 weeks. It also sets into the motion that this is as Dr. Moyo said, this is a team approach. So I do my bit, physio does theirs, and then they are handed off to themselves. They have to continue the healing. And that's where I think that this is really important, because as Val correctly showed, all of those other elements come into play, and you have to get their mindset around, oh, doctor's going to fix me, now I can go fishing. No, doctor's going to create the space, physio is going to elaborate on that, and then you are going to maintain that level of health, including your core and back strength, so that you don't have to come back to see any of us again, or if you do, it's usually physio. Thanks.
Yeah, can I comment?
Yes, of course.
I think a very, very common thing amongst our chronic pain patients is their passivity. They haven't taken on responsibility for their own pain, and to try and get them on board on the team. We're trying hard with the team, but the patient, actually needs to engage and take responsibility for their own body, which is all our job, is to try and let them understand that.
Thank you so much. I think it underpins, what literature says, that 85 to 90% of back pain do not require surgery, and so we have to look at that psychosocial profiling we're talking about, and have an integrated approach to back pain management. Thank you so much for for availing yourself today. We have gone way past our time, but it was really informative, and we have had people on our YouTube channel who couldn't join in. But thank you once again for availing yourself on a Sunday evening, on a Sunday afternoon, and giving us really some educational pearls. We are really, really grateful. If there is no burning comment or question, we'll probably ask each of the presenter for their last remarks. We'll start with Dr. Maraire and then Dr. Moyo and then Val.
Hi, guys. I just wanted to say that was really great. Dr. Mba, well done for organizing. It was a really interesting panel, very engaging. We had different perspectives. I'd like to thank my fellow panelists who I've worked with, especially Val. We've been working, I think, for a long time, and Dr. Moya as well. So thank you for that. I was delighted. It was very interesting. I learned a lot. Thanks.
Thank you. Dr. Moyo?
Thank you for having me, and it's been quite an interesting afternoon. Pain is an interesting subject, and I think it's in order that we're talking about pain. We're celebrating the ICD-11. Finally, they've recognized that pain is a disease. So this is good. Let's have more programs like this, and probably this should be a platform to launch more comprehensive multi-professional programs, which will take us to the future. Thank you.
Thank you. Val?
Thank you so much for having me on, Dr. Mba. It's been an absolute privilege to rub shoulders with these high-profiling people. I think the most important thing for us in the interest of the patient is that we communicate with each other, that we are a team and we are holding their hand through the process, but it's important that we communicate with each other because I think we pretty much are all on the same page, but I don't think we perhaps communicate as well as we should. But thank you for the honor.
Thank you so much. With those wise words, we are gonna close our meeting for today. Thank you once again to our guest presenters for availing themselves. Thank you for a very engaging discussion, and thank you for to everyone who managed to log in today. See you next time.